further. Okay. So, fluid therapy. This is the quite a difficult subject, fluid therapy, because fluids are drugs, and in many cases, in many situations, we forget that as a drug, the fluid must be given cautiously. This presentation was performed by Dr. Dietrich Sommer and me, and we also use some slides, some pictures from the previous presentations that were performed, that were prepared by the former head of our department. So just to make it clear, we have quite a lot of water in our body, and in the older we are, the less water we have. Neonate have about 80% of water. Adult person, about 60% of the body weight is water, and women have less water, and also obese people have less water compared to men and compared to non-obese patients. This water is kept in compartments. Intracellular compartment is, in fact, the biggest one. It contains about 40% of the whole water. Extracellular compartment, it's a mistake, has 20% of water, and what we see as the blood is only 5% of our water. Intravascular compartment is what we really see as a bleeding, as a circulating blood volume. If the patient loses 30% of circulating blood volume, compensatory mechanisms may not be able to restore the normal circulation. So we have to keep in mind that in a normal situation, the fluid compartments are quite well organized, and the water from one to another compartment can pass through the barriers. There can be shifts of water going on, but this shift to one side are almost equal to the shift to another side. So when we are healthy, when we are in good condition, these compartments are stable. This is it happens because of good function of cell membrane and capillary base membrane. Just another picture of how much of water we can find in a healthy 70-kilo person. This percentage shows us that intracellular compartment is about 30 liters, extracellular about 14, plasma or circulating blood volume, which we are usually replacing during the hemorrhage, is about 3.5 liters. So, and it would be ideal if this concentrations, these values will be all the time in our body. Unfortunately, in dehydration, which is the slow, we can say that dehydration is a kind of a slow loss of water. So somebody who is dehydrated, it's someone who's been losing water for some period of time, like an old person who breaks the leg, stays home, has nobody to help, and this person is waiting 1-2 days for help to come. When the person is found by the family or by the neighbors, is usually dehydrated. So dehydration takes time. In hospitals, in intensive therapy, in anesthesiology, we have rather we deal with the patients who are acutely lose water. They use this water, this fluid from blood. So we mainly have patients who are bleeding, who have hemorrhage, and patients who lose water by evaporation, like burned patients, or patients who lose circulating blood volume because of the intra-compartment shifts. These are, for instance, septic patients. I will get back to this later. So aims of rational fluid therapy are to keep, to restore the volume, to provide circulating volume, and this circulating volume which contains erythrocytes, is a carrier of oxygen to the tissues. So without good volume, good expansion of our vessels, we are not able to deliver oxygen to the tissue. So we have to have volume, we need to have pump, and we need to have a carrier to the oxygen. And the second aim of fluid therapy is to keep these physiological compartments in a good shape. And this is much more difficult than just filling the vessels. So it's easier to give patients infusion of some fluid, just make it flow into the veins, compared to choose the proper fluid, the proper volume, the proper rate of infusion to keep or to restore the physiological contents of compartments. This is much more difficult. We have something like third space, which is not important in an everyday life. It's not important, and some people say that this transcellular, this third space does not exist. But we just can feel that there is something. There is a fluid in cerebrospinal fluid, fluid in pleural cavity, in pericardium, in digestive tract. This is, it's not much, but this third space becomes very important in pathology. This third space can, the fluid, even several liters of fluid, of water, can be stored in digestive tract, and can be stored as an ascites in patients' peritoneal cavity. In patients with in pleural cavity, also 2 liters can be stored. This fluid, which is in third space, is unavailable for circulation. So the patient who has ascites, patient with liver cirrhosis, may be full of water, but this water is not circulating. So at the same time, such person with ascites is overhydrated, but hypovolemic. There is water in the body, but this is not circulating water. And so in these circumstances, anatomical and the third space becomes very important. And this space increases in trauma or in after surgery. Surgery, in fact, is also a traumatic situation. So the fluid balance, it can be external when we think about body and the surrounding, and internal when we think about these compartments. So in fact, there's water everywhere outside us and inside us. So how do we give, or what are the reasons for intravenous fluid therapy? Fluid resuscitation. I'm sure that you've heard the word resuscitation, and you usually connected this word with CPR, cardiopulmonary resuscitation. So resuscitation is something that is done rapidly in a fast way. This is the same with fluid resuscitation. When we give the patients fluid in a high rate, because of patient's poor condition, because of the bleeding, because of the hemorrhage, because of the sepsis, we resuscitate the patients with fluids. On the second, And on the opposite side, there is a routine maintenance. Routine maintenance is giving some fluid to somebody who cannot take them by himself. For instance, the patient who cannot drink because is somnolent. The patients after some neurological issues, injuries, cannot take the bottle, cannot take the glass and drink by itself. So this person has to receive fluids intravenously because he or she cannot meet normal requirements of water and electrolytes. So this routine maintenance is characteristic by rather slow infusion of fluid. Remember that when we give fluid slowly, they have chance to fill in the compartments in a better way compared to the fast infusion. In a fast infusion, at the beginning, most is in the vessels. Then, in most cases, a lot of this fluid goes into the tissues, interstitial tissue, causes edema. So it's when there is really no need for fluid resuscitation, don't give patients fluid too rapidly. And also we give fluids as a replacement. Replacement therapy. Replacement means that we have to replace something that has been lost or is being lost at this moment. So, for instance, somebody who loses fluids through the drains, who has diarrhea, somebody who really loses the fluid, but not as urgently as somebody who needs resuscitation. And these losses that need replacement are mostly from urinary tracts, and somebody who has huge diuresis requires replacement. Somebody who has diarrhea or vomiting, also somebody who loses fluid through the evaporation as a result of fever. Burned patients can lose extremely high volumes because of the open wounds, and this volume is additionally rich in albumin, and with albumin the fluid is drawn, so they really lost a lot, huge volumes. If these losses are going on slowly, the organism is able to compensate, but still this compensation is only for some period of time. Without external infusion, we cannot just make the shifts. The fluids in our body cannot be shifted just for days. So we need to give these patients fluid. And the last one, the reason is to correct the redistribution. The redistribution occurs in pathology when this anatomical third space is increasing. So we have the redistribution is we are trying to fill in the compartments in somebody who has at the same time a lot of water in the body. So this is really it's difficult in sepsis, in major surgeries, in ascites. This redistribution must be compensated by fluids, by external fluids therapy. So urgent fluid resuscitation is necessary when the patient loses acutely the circulating blood volume. Normally, at the beginning of hypovolemia, at the beginning of dehydration, our body compensates, turns on the compensatory mechanisms, which are effective until some moment. If 30% of circulating blood volume is lost, there will be really problem with compensation. If more than 40, the patient without urgent therapy will surely die. The first very visible symptom is increasing the heart rate. So somebody who is hypovolemic, who is dehydrated, will have increased heart rate, except those patients who receive beta blockers or who are on drugs that decrease or prevent tachycardia. Those patients may have problems. Their body may have problems with compensation of hypovolemia. Peripheral vasoconstriction occurs, and it helps to increase diastolic blood pressure and just to kind of squeeze the vessels, and by this to increase the tissue perfusion. However, you will learn in the future that blood pressure is not, that we cannot only rely on blood pressure in terms of oxygen delivery to the tissues. Some patients may have quite good blood pressure, but they will, the delivery of oxygen to the tissue will not be enough, and because the cardiac output is not enough, so the pump is not able to pump, the heart is not able to pump blood correctly, and the blood pressure is maybe not normal, but it's still not so low. So we are used to look at the blood pressure, but we have to keep in mind that in severely sick patients, for monitoring, blood pressure is not enough. If more than 30–40% of intravascular volume has been lost, usually dysfunction of multiple organs occurs. Dysfunction of every organ, in fact. Mental disorders may occur. Respiratory insufficiency, maybe not at the beginning, but for sure the renal, the urinary output will be decreased as a symptom of decreased perfusion of abdominal organs. And it's very easy to diagnose whether the kidneys are correctly perfused or not in hypovolemic patients. We just need to measure volume of urine that is produced hourly. So minimal effective perfusion of kidneys is between 0.5 and 1 milliliters per kilo per hour. If patient's urine output during an hour is equal to this value, 0.5 to 1 milliliters per kilo of body weight per hour, it means that kidneys are perfused enough. If the volume decreases, then we need to really think what's happening in hypovolemic patients. For sure, kidneys are not perfused correctly. So easy to check. It's very easy to check these parameters. The patient needs to have a Foley catheter. We will not be able to measure urine output if the patient has no urinary catheter, and only this can allow us to measure our uresis hour by hour. In lab, we see acidosis, metabolic acidosis, as a result of inadequate delivery oxygen to the tissue. So we give the patients fluid. We give the patients fluid urgently, and we also give the fluids slowly, depends on the patient's condition. If the patient is not severely hypovolemic patient because of the bleeding or hemorrhage or sepsis, then we give patients just this maintenance fluid. But in some group of patients, like old people, frail patients, patients with kidney impairment, chronic kidney impairment, or cardiac failure, or those in them we cannot give fluid rapidly because we risk pulmonary edema, the occurrence of pulmonary edema. If patients are malnourished, they are at risk of refeeding syndrome. Of course, this refeeding syndrome or problem with nutrition will not be increased by intravenous fluids delivery, but sometimes when you think about intravenous fluid, you also think, or we think, as the parenteral nutrition. Parenteral nutrition can be given in parenteral is given parenterally, intravenously, and it's a volume. So if we give somebody parenteral nutrition, we have to calculate this volume. It's usually 1 to more liters per day in an everyday balance. And in those patients who are malnourished and at the risk of refeeding syndrome, we have to give parenteral nutrition very, very slowly. But I'm talking here about the parenteral nutrition just because this is something written about refeeding syndrome and this on this picture. But generally, remember, parenteral nutrition is not fluid for fluid resuscitation. It's not a normal type of fluid. It is fluid, it is a volume, but the indications are not dehydration or hypovolemia. Indications for parenteral nutrition is inability of enteral nutrition. So this is something that you should not connect with fluid resuscitation or intravenous fluid therapy. If possible, if the patient is stable, the fluid should be given during the day. So at night, the patient doesn't have to be waken up by the nurse who needs to change the infusion set, etc. Normally, if we should keep in mind that there is something like day at night, and it's good not to mess with that. However, in a hospital, it's hard to achieve this exact division between or differentiation between night and day. And somebody who is not bleeding, who just requires fluid for maintenance, will require about 25-30 milliliters per kilo of water per day. This is so you can calculate how much it is. And as a human being, as a people, we need our fluid balance in a healthy person is equal requirements to losses. So usually our intake is about 2.5 liters. This water, we drink the water, we have water in food, and water is produced during the metabolic processes, and the same volume must be lost. So we, on average, a healthy person keeps the weight. So we do not, we have to intake and losses must be equal, and our weight is quite normal. In sick patients is not so easy. The second, another possibility how to calculate how much our patients require is a rule 4:1. If you want to find out how much of water your patient requires, just the basic water, losses are not incorporated in that. This is just volume necessary for being normally hydrated. So the basic fluid requirements is 4 meters per kilo per hour per every kilo between 1 and 10. Between 11 and 20, we calculate 2 milliliters per kilo per hour. and every kilo over 20 is 1 meters per kilo per hour. So this calculation is for 70% will be 4 milliliters by 10 kilo, then 2 milliliters for every kilo between 11 and 20, and 1 milliliters for every kilo over 70. So we have 10 kilo, 20, and 50. The sum is 70 kilo. And per hour, it will make around 110 milliliters. Multiplied by 24 is around 2.5. So this is something that normal person during the day usually requires. Normal, healthy person. Somebody who is not healthy, who has fever, requires extra fluids. And it's very hard to say how much. If there's a high fever and heavy perspiration, 1 or 2, even 2 liters a day might be necessary. About how to calculate it, no, you can try to calculate that, but per 1 kilo, per 1 degree centigrade over 37, the patient loses a quarter of liter. But this calculation is not very precise, and in some books we can find that it's 350 or 500. So this is really not very precise. When we give fluid, we need to give correct fluid. I don't know whether you will come to ICU for the exercises or not because of this quarantine and isolation. But when we prescribe fluids to our stable patients, we always calculate we also think about other sources of water that we give to the patient. So let's say if we need to give the patient 2.5 liters, it's not only 2.5 liters of intravenous fluid like Optilite or other solution. We also calculate enteral feeding if the patient, for calculation of the volume. We also calculate the parenteral feeding if we give the patients, and we also have to keep in mind that some drugs given to the patients are solutions also in water or in natrium chloride, and these volumes also add to the volume that we give to the patient. So at the bedside, we have to really look what the patient receives, and then all this is added, and we have to check how is the urine output, how much the patient loses. If the patient loses, if the balance is too negative, I mean there is too much losses compared to the fluids given, we add extra fluid or we decrease the dose of diuretics. It depends. If on the other side, too high volume was given to the patients compared to the losses, we cannot draw what is given to the patients, so we have to increase the losses. The easiest way to increase the losses is to increase the urine output, so we give diuretics, just to make the balance correct for the patients. If the patient receives, receives not enough fluid, it's not good. If the patient receives too much fluid, it's also not good. In physiology, water, which is in the vessels, blood vessels, is shifted to the interstitial tissue, then lymphatic system collects it and draws it back to the circulation. If the patient receives too much fluid, the blood barrier endothelium of the vessels is damaged, then too much fluid passes through the interstitium, and lymphatic system is no longer able to transfer transport all that fluid back to the circulation. What we observe, we then observe tissue edema. And this lymphatic system becomes ineffective, or maybe it not becomes ineffective. The mechanisms are ineffective because too much water is in the interstitial compartment, in patients with sepsis, in patients after the major trauma, after the major surgery. So when students come to ICU and we have the patient who is in sepsis, in septic shock, then they always say, "Oh, doctor, why this patient is so edematous? Why there is an edema on the face, on the hand?" This edema is because the fluids that we give to the patients cannot be correctly transported into the circulation in this acute phase. When acute phase of disease passes, then slowly edema decreases because the lymphatic system becomes effective. And during the pathology, there are two types of shifts from capillary to interstitial compartment. Type 1 is normal. So this is this continuous transfer of water, and effective function of lymphatic system prevents from the edema, from formation of edema. But when we give too much fluid, this mechanism is not effective. And when there is a pathology, damaged capillary barrier, and rich in protein plasma, water shifts to the interstitial compartment, then we become edematous. When this glycocalyx becomes damaged, in many situations, trauma, sepsis, hemorrhage, surgery, acute hypervolemia, and unfortunately, this edema occurs within an hour and lasts for a few days. And believe me, sometimes when we, just to make it easier, when we admit in the evening the patient in after the trauma, multiple trauma, in hemorrhagic shock, we give fluids, we give blood products, we give fluids, we give blood products, just to keep the circulating volume effective. In the morning, the patient will be really very edematous, will be swollen, and this edema, if the patient survives this trauma, then this edema lasts for a few days. And this edema, what we see is superficial. We see that the patient's face becomes more rounded, that the hands are more edematous. So what we do not see, but it exists, why not, is the edema of lungs, is the brain edema. Maybe not brain is quite, if there is no brain injury, a brain trauma, then the brain luckily is able to stay in a good shape. But in lungs, there might be interstitial edema, not the edema like you know from the cardiology, because of the caused by the cardiac disturbances, but the edema in the interstitial compartment. Edema can be observed in the intestines as ileus. So the patients who are severely edematous, they have ileus, they have problems with absorption of enteral feeding. So because we see only what is outside, we do not see what is inside, but we know that inside there's also edema. And this picture shows us quite good what happens with the glycocalyx in a pathology. This is on the upper part, you have physiologic situation. And when glycocalyx is correct, healthy, there are plasma proteins circulating. This is the external part of the vessel. And here we have pathology, trauma, operation, sepsis. There is no glycocalyx, it's damaged. There is the endothelium is permeable to water and to the proteins. And you can imagine that this water and proteins easily pass through the damaged endothelial cells into the interstitial part of the tissue of the every organ, and edema increases. So what we have to keep in mind also is that most of the effective circulatory volume is in the arterial system. The venous system is a storage, high storage or high volume, 85% of the circulating volume. And what is lost at the beginning is the loss from the effective circulatory volume, and it's observed as a hypovolemia. Hypovolemia means that there is a disproportion between the circulating blood volume and the vessel's capacity. As I said, the volumes, if a lot of circulating blood is lost, then clinical signs occurs, or the patient die if this loss is going on and going on without replacement. MOF means multi-organ failure. So many organs fail, and without intensive therapy, patient will die. Many patients die also despite intensive therapy. If the multi-organ failure is very pronounced, very severe, we cannot regain the normal function of the organs. That's why if the patient is losing fluid, becomes hypovolemic, it's good. The best way is to start to replace fluid as early as possible. Okay, so we have absolute and relative hypovolemia, and this picture we will see also in the seminar about the shock, if I'm correct. So absolute hypovolemia is when the fluid is really lost outside. Hemorrhage, burns, digestive tract losses, or renal losses. This fluid is lost outside the body. Relative hypovolemia means that there is no external losses, but the capacity of the vessels suddenly is not equal to the circulating volume. If we have high spinal cord transection, vessels dilate. Dilation of vessels means that the capacity of the veins and arteries increases. The volume is still the same. Same situation with anaphylaxis or septic shock. Dilation of vessels, circulating volume still the same, this 3.5 liters. Sympathetic block caused by anesthesia, that's what we do to the patients. We perform spinal or epidural anesthesia. This anesthesia, local anesthesia, causes blockage of sympathetic system, and vessels, arteries are constricted because of the sympathetic impulsation. If there is no sympathetic impulsation, then the vessel delayed, and again, capacity of these vessels increases. And if we give the vasodilators like nitroglycerin, if we give sedative drugs or some narcotics, also this sympathetic block or dilation of the vessels by another mechanisms occur. So in absolute hypovolemia, fluid is lost. In relative hypovolemia, fluid is not lost outside the organism, but the capacity is too high in compared to the circulating blood volume, or maybe in another direction. Circulating blood volume is not enough compared to the suddenly increased capacity of blood vessels. How can we find out whether our patient requires fluid, loses fluid, how much of it should be given? It's hard, it's really difficult. The best way would be to check the patient's weight. It's easy. If the weight is increases, so the patient must get something. What the patient might receive? Fluid, enteral nutrition. If the weight decreases, it means that the patient lost weight. The problem is that how to weight the patients, how to check the weight of critically ill patients. The beds that we have in ICU, they have incorporated weight inside, so we can check the patient's body weight. However, the steps are 500 milligrams. So I can only see the difference that is higher than 500 milligrams, half of the kilo. So this is high step. This is the big difference. For children, for neonates, for newborns, of course, it's much easier, and they are weighed every day because then the weights are much more precise. Fluid balance calculation in milliliters. That's what our nurses do. They calculate how much the patient received the fluid, how much the patient lost the fluid. But it is useful, but we have to keep in mind that this calculation are often inaccurate because the assessment of how much the patient lost through evaporation is really difficult. They can easily measure urine output. They can maybe not measure, but just try to say how much of the stool the patient loses, or with diarrhea, or water with diarrhea. But this is not very precise. We check skin turgor and capillary refill. It can be useful, but might be affected by other causes like cachexia and old age. And skin turgor will not give us any information if there's an urgent loss of, if there's a hemorrhage, urgent hemorrhage, because the skin requires some time just to become less I hope they understand that less sprężysta, less dense. And we measure urine output. Half is the minimum, between half and 1 is okay. Yes, 1 and this is the minimum that we can accept. We also, if possible, we should find out what happened with the patients prior the admission. So the history, if the patient is unconscious, you cannot get the history. So often we ask, we rely on the documentation in the hospital, or if there is a family, next of kin of the patient, somebody who knows the patient, then the information from this person may be helpful. Physical examination, we check body temperature. If the patient is in shock, if there is a centralization of circulation, then the skin will be cold. And the core, the deep temperature will be normal or even increased. This diuresis is measured, and some patients have hidden hypovolemia. So when they are not intubated, when they are not sedated, they have sympathetic system functioning. If we give the patient sedative and we intubate the patients, by the sedative, we decrease the sympathetic impulsation. By mechanical ventilation, we totally change the pressure in the chest. So those patients who are hypovolemic but with functioning compensatory mechanism become deeply hypovolemic when intubated and sedated. We check hemodynamic measurements, which can be basic, not the best, especially in critical condition, and advanced. Some may be less or more invasive, depends on the patient's condition, on indications, on the availability of the devices in the hospital, and the indications. You can say that during the operation, in most cases, less invasive are enough monitors. In the intensive care, this monitoring should be more invasive. We check lactates in the blood, capillary refill time, we look at the skin, but there is no single marker for assessment. There is no lab result which will give us some informations, but there is no gold standard. We have to look at all these elements and create one picture of a patient. I'm trying to tell you that assessment of patient's fluid condition is difficult. Please do not rely on central venous pressure when used or pulmonary arterial wedge pressure. This is the CVP, is the pressure measured in the vena cava superior. Pulmonary artery occlusion pressure is the pressure measured in the pulmonary artery. They are not good as they should be not used as markers of fluid therapy of patients' volemic condition status. So it's better to check other parameters, cardiac output, stroke volume. This is I hope that this picture will stay in your mind for many years, and you will, because on this picture you can see that if you look at the CVP, and I'm sure that during this few years of training, you will see somebody saying, how is the patient's volemic condition? Okay, let's measure CVP. CVP is low, the patient is dehydrated or hypovolemic, or CVP is high, so the patient does not require fluid. It's not so easy, because these are the dots shows the measurements in the patients of CVP, and the patients some of those patients were on the right side, you have hypovolemic, hypervolemic patients with positive fluid balance. On the left side, you have hypovolemic patients, and there's mess. There is no way that you can say that somebody who has plus 2 liters has always high CVP. No, some patients had CVP around 5. On the other side, there were patients with fluid deficit with CVP 20. So no way to rely on. We can use CVP if it's low, the patient is hypovolemic, we give fluid and we see that CVP increases. So we observe the trend. The trend is good. It means that my treatment is going properly, correctly. So the trend is fine, but the value the one single value is really not helpful. We can rely on CVP if we have other measurements like cardiac output. So if the cardiac output decreases and CVP increases, it means that the heart is getting sick. Patients with chronic heart insufficiency or with decreased cardiac heart contractility, they have low cardiac output and high CVP. They have high CVP because of poor heart function, not because they are fluid overloaded. And the same, if the cardiac output decreases and CVP decreases, probably decreased venous return, and probably, not sure, decreased circulating blood volume. So CVP plus other measurement can be helpful, and trend, analysis of the trend, not of a single values. Only if they're extreme values, we can just say that maybe there is something going. But we may say, okay, probably if there's high values, the patient heart does not constrict correctly. If it's low value of CVP and possible fluid losses, and CVP increases with fluid therapy, probably the patient is hypovolemic. But the problem is that there is no normal value also. In different books, you can find different values. Usually, it says that the normal range is between 6 and 10. In the other book, it's written 8 and 12. So not so easy. CVP might be helpful in diagnosis of tamponade. It will increase. right ventricle dysfunction, maybe in hypervolemia, maybe, but remember that not correctly constricted heart will give us the high CVP. So maybe hypervolemia if we know that the heart is correct, is constricting correctly. With high CVP, okay, we can say heart is fine, it's high CVP, maybe probably hypervolemia, but this is still not sure. For sure, we cannot rely on CVP if we want to find out whether my patient requires fluid or not. To know whether the patient requires fluid or not, we have to check some better parameters, which are called dynamic parameters. They will be shown in a moment. We assess volumetric parameters by echocardiography. This is difficult assessment if somebody is not able to perform echocardiography, is not able to see the picture correctly, and echocardiography is a measurement that is done at the moment. Then it's not a continuous one. What we do is we measure we measure cardiac output using special devices. And the special devices is called PICO device in ICU. And with PICO device, we can check how stroke volumes, consecutive stroke volumes, are equal or not. If somebody is well filled with water, then the stroke volume will be stable. If the patient is hypovolemic, one stroke volume will be higher, the other lower, there will be the mass. And this mass is given as a value in percentage, in percent. The problem is that for us, it's not a problem. The problem is for us intensive therapy doctors. The problem is that those measurements, dynamic parameters, requires intubated patients, sedated without active breathing. So rest ventilator must be working on, and the volumes of each breath must be quite high, and the patient cannot have heart rate disturbances. So sinus cardiac rhythm, mechanical ventilation with high volumes, and without active patient's breathing activity. Then we receive when we put the catheter, we turn on the measurement, and in those non-breathing, ventilated, cardiac with good cardiac rhythm patients, we receive something like that. We receive the volume, that stroke volume variation or pulse pressure variation, their surrogate, is percent, 12 or 13, depends. And if the value is around this range, and this in hypovolemic patients, the good treatment would be probably giving fluid. If it's lower, if it's 5-6%, it means that your patients in shock is not hypovolemic. Look for another reasons of the shock. Maybe there's a cardiac, maybe there's a stroke, maybe myocardial infarction. Maybe the patient is has low hemoglobin. Look for another reason of shock, of decreased tissue delivery to the oxygen delivery to the tissue. Somebody with low value is not a person who requires fluid. It's not fluid responsive patients. So stroke volume, it's calculated by the computer. Pulse pressure variation is a difference between systolic and diastolic. You can see that this difference here is high, here this difference is low, and the computer calculates several measurements, and also give us the information that pulse pressure variation is again 15%. So I can give the patient's fluid. If it's 5 or less than 9, I cannot give the patient's fluid. If this value of pulse pressure or stroke volume variation is between 9 and 12, 10 and 12, unfortunately, it's a gray zone, and it's not so easy to say whether the patient requires fluid or not. Well, this is the PICO technology. That's what we use in our critically ill patients. We put an arterial catheter in the artery. We put a venous catheter in a vein. And we connect it to the monitor, and we inject cold saline into the vein. This is the sensor. This cold saline, it passes through the lungs, so it's thermodilution, pulmonary thermodilution, and it goes right after into the artery. There is another sensor of the temperature, and the computer, using the difference of the temperature here, difference of the temperature caused by the injection of the cold saline, makes all the measurements: cardiac output, stroke volume variation, pulse pressure variation, and other many measurements can be we can get from the PICO catheter. So it's not very complicated. It's semi-invasive and very precise. This is the best way to assess the patient's hemodynamic condition. The gold standard is Swan-Ganz catheter that is inserted into the vein and into the pulmonary artery, but it's very invasive. So just to make life easier for the doctors, less invasive monitor like PICO has been created many years ago, and in the ICU, in most cases we use PICO. We very seldom use Swan-Ganz catheter. Swan-Ganz catheter is used in the cardiosurgery usually, or in cardiology. So I said that those patients, that all these parameters can be measured, can be reliable only in patients who are not breathing spontaneously, who are mechanically ventilated with high volumes, who have normal cardiac rhythm. But not all the patients are like this. Some patients are conscious, spontaneously breathing patients, or even maybe not conscious, but may have spontaneous breath. So the very good indicator whether our patient requires fluid or not is a passive leg raising maneuver. We need to device that calculates cardiac output in real time. So we need cardiac output monitor connected to the patients, invasive or non-invasive. It's not so important. We measure cardiac output, then we change the patient's position in the bed to this one. We check the cardiac output. In the cardiac output, if the cardiac output increases by 10–15%, it means that the patient requires fluid. Why? Because increase of cardiac output means that the patient is fluid responsive. The fluid given from the legs, about 300 milliliters of blood, shifted to the central compartment, caused this increase. Then we need to get patients back to the initial position and check whether this cardiac output decreases. Because when we put the patient back to the initial position, then this fluid goes back into the leg. And if cardiac output decreases to the initial value, to the one from the time before the maneuver, means that this increase was caused by the fluid shift. If the cardiac output does not decrease, is still high after the returning of the patient to the normal position, probably something else caused this increase. Maybe it was the pain that we created to the patient by movement of his position. So the positive result of this maneuver is temporary increase of cardiac output caused by fluid shift from the legs. And this passive leg raising has been created as something that could replace classic fluid challenge. Fluid challenge means giving patients boluses of fluid within 100, 200 meters within 5-10 minutes, and then we check whether cardiac output increases or not. But it's possible to give patients too much fluid because we give fluid, cardiac output does not increase. So we give more fluid, cardiac output still does not increase, and then suddenly we gave 1 liter within 20 minutes. Okay, and the patient is now hypervolemic and starts to have pulmonary edema. So because if we give the fluid like this in a classic way, we give it to the patients. So we risk of iatrogenic hypervolemia. If we use passive leg raising maneuver, it's only a temporary transient infusion. It can be reversed and it is reversed by putting the patients in a normal position. So we give the fluid. If we decided that our patients require fluid, we need to give the good fluid, the proper fluid. So we give fluid to prevent ongoing losses, to replace previous losses, to provide hemodynamic stabilization, to improve circulation, and to optimize oxygen delivery to the tissues. Hypovolemic shock is a very good, very easy type of shock to explain what we do. We have to check for vascular resistance, turgor, thirst, oliguria, low systemic pulmonary preloads, rapid heart rates. Patient may lose fluids through different mechanisms, and we have to treat him or her. So first the rescue, fast giving fluid. Then there is optimization phase, so we decrease the rate of fluid. Then there's a stabilization, the fluid rate is very stable. And then there is a de-escalation, we have to remove the fluid from the patient, who is usually edematous, filled with too much fluid. And I'm not going to discuss it because it's too much for you, but during the resuscitation, optimization, stabilization, de-escalation period phase, we have some things to do and to check. We give fluid, we give vasopressors, then we have to decrease the dose of fluid, decrease the dose of vasopressors, increase the urinary output. Sometimes we have to connect the patient to the device that replaces the kidneys if the patient has acute kidney injury and is not urinating at all. How we can remove the fluid? We can only use it by dialysis. So in many cases, we, in this de-escalation phase, or sometimes earlier, we use dialysis just to remove fluids from the patient. Because if the patient is fluid deficit or fluid overloaded or given incorrect fluids, increased morbidity and mortality is observed. So if we don't give patients enough fluid, then the patient will be dehydrated with hemoconcentration, poor cardiac output, decreased delivery oxygen to the tissue, and then compensation mechanisms will start to work. At some moment they will not be effective enough, and the patient will die in multi-organ failure. On the other hand, if we give too much fluid, we will increase edema, intra-abdominal hypertension, respiratory failure, impaired healing of wounds, altered mobilization of the patient, and also multi-organ failure can be caused by hypervolemia. This you will have this. This you can also see. You can see that every organ can have pathology caused by hypervolemia. As I said, that we see edema on the patient's face or on the patient's under the skin, but we do not see the edema that is in the tissue. And believe me, it is in every tissue, in every organ, and every organ will show us that the patient, that his or that its function is deteriorating because of the edema. So that's the one reason of deterioration, of course, low perfusion caused by edema. There is no ideal resuscitate. Another difficult task is to choose the proper fluid. We would like to have something ideal. The ideal fluid is plasma, is our blood, our plasma. And nothing identical hasn't been created. So ideal fluid should be easy to increase the volume without accumulation. The composition should be like plasma. There should improve results outcome in patient with acute cardiovascular insufficiency. It should be also cheap. It does not exist. So what we give to the patients? We give something that we give what we have. We have crystalloids or colloids to choose from. Blood and blood products are not a part of a resuscitation therapy or fluid therapy. They are part of treatment of hemorrhage or a part of treatment of coagulation disorders, low platelets. It depends on the patient's condition. But when we talk about the fluid therapy, we don't think about the blood and blood products. We think about crystalloids and colloids. Crystalloids can be hypotonic with respect to plasma, isotonic, or hypertonic. For fluid resuscitation, rapid giving fluids, we usually use isotonic and sometimes hypertonic solution, but most cases isotonic solution are used. Once the crystalloids are given to the patients, they go into the vessels, and then very rapidly, quite a lot of this volume goes outside the vessels. So only 1/4, 1/3 of the volume administered remains intravascular. So in the urgent scenario, if we want to replace what is being lost, we have to give 2 or 6 times more fluid compared to the blood losses. So if the patient loses 1 liter of blood, the patient should receive between 2 and 3 or 2 or from 2 to 6 liters of the crystalloid to replace the loss of 1 liter of blood. But in stable in some situations, part of the interstitial compartment is inaccessible for fluid. So in some circumstances, this shift can be decreased between compartments. It happens during anesthesia. So in stable condition, we should give fluid slowly. In unstable, just to survive, to keep the patients alive, we have to give it fast. And there are some rules how to dose how to give the fluids. So during the first half an hour, we give loss multiplied by 1.5. Next 30 minutes, we give this loss multiplied by 0.5, and next 30 minutes, we give less fluids. Do we really use it in an urgent situation, this rule? Unfortunately not, because when it's an urgent situation, we just pour the water into the patient's vein. And theoretically, just for the best results, it should be done slowly. In the anesthesia field, because in the anesthesia, there are usually healthy patients. In ICU, there are sick patients. So in the anesthesia field, there are new findings that as long as the crystalloid is infused, most of it stays in the intravascular compartment for about half an hour. If there's a sudden hypotension, then this volume stays whole volume transfused again for about half an hour, 20 minutes. Then new balance occurs. But sometimes during anesthesia, when there is a sudden hypovolemia, sudden hypotension, because the hemorrhage, for instance, this 20-30 minutes gives time for the operator to decrease the bleeding, to stop the bleeding. So these new findings are very good for anesthetized patients. Unfortunately, for critically ill patients, ICU patients, it's still not true. The truth is that most of what we infuse goes into the tissues. You will never, of course, you don't have to learn the composition of some crystalloids. Trade names differ between countries. This table is just to show you that different fluids have different composition, different ions. Sodium chloride there is always, and the other ions are given depending into the are in the solution depending on the product. Please remember that sodium chloride is not normal nor physiological. There are totally different concentration of ions in the plasma. There are no bicarbonate, there are no metabolizable anions to prevent acidosis. And if you give a lot of fluid, a lot of this sodium chloride, metabolic acidosis occurs. Can we use it sodium sometimes? Yes, we can. In hyponatremic patients, so those who have low sodium, in some brain injury patients. Hypochloremic acidosis caused by massive infusion of sodium chloride decreases granular blood flow, induced nitric oxide synthesis. Nitric oxide is a potential vasodilator, so the vasodilation of vessels occurs. Cells becomes impaired, blood flow in splanchnic region decreases, a risk of bleeding because of the coagulation impairment, gastric dying is decreased, contractility of the of heart is also decreased. Luckily, it passes, so it's not it takes some time, but it passes by. But the use of sodium chloride might be cautious. Same with 5% glucose. Please remember, this is not a source of calories. Don't treat 5% glucose as a nutrition. Don't give it as to somebody who, in your opinion, requires energy. If you want to give glucose as a nutrition, give 20, 40, 50% of glucose. This is the source of energy. 5% glucose will rapidly, almost right after infusion, will be metabolized just to water and CO2. So this is the clear water that we give to the patients. As a clear water, it decreases serum osmolarity, increases water content in brain because causes hyponatremia. So in somebody who has brain edema, who has brain injury, never give this solution because you will kill the patients with this solution. In most cases, the solution is used as a solvent for the drugs. This is in our ICU, in fact, is main indication for this solution, just to make, because some drugs requires this solution as a solvent. Ringer lactate is a buffered solution, means that there are metabolizable anion that prevent acidosis. Ringer lactate or Hartmann solution depends on the country, the name. They may differ a little bit between countries, but they are similar to plasma in terms of electrolytes, a little bit lower osmolarity, and this is quite a good solution to give to the patient. But if you want to if you want to treat the patient in shock, and you want to check whether your treatment is effective, you want to measure lactate in a patient's blood. This is lactates is a marker of tissue acidosis. So if you treat this patient in whom you want to check lactates in the blood with Ringer lactate, then you will not know whether the increase of lactates in patient's blood is caused by your improper treatment, acidosis increases, or because you infused Ringer lactate. So if you want to use lactates in the patient's blood as a marker of hypoxia, do not treat the patient with a solution that contains lactate. Choose another balanced crystalloid solution. They might have another metabolizable anion. Preferred type of crystalloid in everyday practice is a balanced crystalloid solution. I don't want to give the names for you, but I give it. But I don't know what you will have in your country. So we have Optilite, for instance, as a commonly used, or Sterofundin ISO. They have metabolizable anion. Names of the solutions are not so important at this moment. For you, important is to know what is balanced solution, and remember that these balanced solutions are the good fluids to be given to the patients. Hypertonic saline solution we use in small volumes resuscitation, and we also use in the brain edema treatment. In brain edema treatment, patients, we want them to have high sodium in the blood. So we use hypertonic saline, which lead to decrease of brain edema, or not, depends on the patient's condition, of the patient. But generally, idea of using it is to decrease the edema. Some patients react to this, some don't. Yes, so hypertonic solution increases arterial pressure, decreases edema formation, increases sodium osmolarity of the blood and chloride. This is not good, in fact, but sodium chloride in some patients increases is correct in brain edema patients. Urinary output increases in patients. It also on immune systems. There is an influence, but in animals, not in humans. And mortality, ICU treatment, ventilatory days may be decreased by using hypertonic solution. So in post-traumatic acute hypovolemia or in patient with increased ICP, some say that there are controversies. If sodium chloride in patients' blood is too high, we should not give saline. So we have to just check sodium in patients' blood. In cardiogenic hemorrhagic shock, possible, but not always effective in the early phase of the burned patients. The second type of fluids that we give are colloids, which are suspension of high molecular weight particles from gelatin, protein, or starch, are suspended in saline, glucose solution, or finally in balanced solution. These which are suspended in balanced solution are the best. They better expand plasma compared to crystalloids, so less volume are necessary. They don't have such potential of causing edema. Unfortunately, they cause allergy, coagulopathy, have influence on blood cross matching, and they have some short time half-life. Some of them have short, some have longer time in half-life time, and they do not stay. So the effect is transient, and they are more expensive versus crystalloids. You know that we have our albumins. They have different function in the organism. Albumins as a colloid infusion are not the best way of increasing the patient's blood. Only part of it stays intravascularly. They bind water. So in some patients, it's a wrong situation when there's damaged endothelium. Albumins goes into the tissue and water goes with them. So instead of keeping blood water in the vessels, we increase edema, interstitial edema. They have risk of pyrexia, shiver, hypotension. They are relatively safe, but the prions can be transferred. Infusion decreases the production of own albumins, and there is some worldwide tendency to use it more often compared to the previous years as a main colloid in the ICU. But still, we have to be very cautious. should not be used as a volume expander, should not be used as a supplementation in hypoalbuminemic critically ill patients, should not be used in patients with head trauma, and with patients with acute kidney injury, because they increase the risk of AKI. The second colloids that exist are dextrans. I'm not going to talk a lot about them, just remember that they exist. They are not a commonly used colloid worldwide. They were a short effect of time. They have maximal daily dose. They have potential of creation of acute kidney injury. They increase the fibrinolysis, so they enhance bleeding. They may have anaphylactic reactions, may cause. They influence on blood cross matching. Dextran 40 was used as a something that improves rheology, that helps erythrocytes changing the shape and helps them to go into narrow vessels. So transplant surgeons use Dextran 40 just to increase the possibility to deliver oxygen to the very narrow transplanted or sutured vessels. It's not used for fluid resuscitation. We have gelatins from bovine collagen, which will give only short effect of increasing the volume. In fact, they are the only colloid nowadays used because of some guidelines. They do not accumulate in the body, they don't cause acute kidney injury, they do not influence on blood cross matching, they might be allergic. There is a still risk of transmission of prion disease. For many years, hydroxyethyl starches were used as a main colloid. Hydroxyethyl starch is made from starch or potato. These are big particles which are mixed with water, and when given intravenously in the organism, they are cut by enzymes to smaller pieces, and the small pieces are removed by the kidneys. Unfortunately, they have some bad influence on the patient's outcome. And in 2012, hydroxyethyl starch there was a statement saying that hydroxyethyl starch should not be used. These are the names, forget about the values. Hydroxyethyl starch should not be used in sepsis patients, in patients with risk of acute kidney injury. Gelatins should not be used in those, this is the suggestion, gelatin should not be used in those patients. Colloid should not be used in head trauma patients. Gelatins should not be used in organ donors. Hyperoncotic solutions should not be used in resuscitation. Hyperoncotic solutions are the mixtures of colloids with hypertonic saline. In Sweden, in Germany, they are available such solution. In Poland, no longer exist. And this recommendation, after this recommendation, the use of hydroxyethyl starches, the use of colloids really decreased in many countries. Colloids, hydroxyethyl starches cause coagulopathy in acute kidney injury. The big particles may accumulate in tissue and cause swelling, itching for weeks. They increase serum alpha amylase concentration. The big old were causing this. Then the new, smaller, medium molecular weight were invented, and they had much less negative effects on hemostasis. They improved blood rheology, they inhibit inflammation, but they still accumulate in tissue, but less compared to the big particles. Yes, so these are the big particles or medium particles or small particles of the hydroxyethyl starch. But the general idea is that hydroxyethyl starch should not be used in clinical scenario, despite one indication, actively bleeding patient. So if somebody asks you where you can use hydroxyethyl starch, the answer is actively bleeding patient. And if we use hydroxyethyl starch in actively bleeding patients, we should use the solution that is called balance. Tetraspan, Volulite, depends what you have in your countries. Balanced solution means that they have concentration of sodium chloride, other anions similar to plasma, and have metabolizable anions. But it's not so easy nowadays with hydroxyethyl starches, with colloids. The general idea, the general tendency is to decrease the use of it. That's what I already said. The mixtures of hypertonic solution and colloid I mentioned, they are used less common in Sweden, Germany, they exist in Poland. They do not exist. They increase the effect of hypertonic solution and colloid is the augmentation of volume expansion caused by colloid and by hypertonic solution. So the positive effects of volume increase is synergistic. But they can be harmful because they have too much sodium, they cause AKI, overload circulation, electrolyte imbalance, they may increase intracranial pressure, this hypertonic saline crystalloid and colloid in this mixture decrease cardiac output, increases heart rhythm disturbances, can cause anaphylactic reaction, hyperosmolar coma, and seizures. So generally, these mixtures of hypertonic solution and saline solution and colloids are not very good to use. And artificial colloids, depending on the dose, depending on the time, increase the volume differently. So this is by 100 milliliters, then 200 milliliters, and the time that for how long they stay in the intravascular compartment is also different. You see different solutions. This is the time, this is the volume expansion. Just to finish, in surviving sepsis, we use crystalloids as the initial fluid of choice. We do not use hydroxyethyl starch. We may use albumin in a very early phase of sepsis. We give this crystalloids, we give as a bolus of 30 milliliters per kilo as fast as possible. And we should perform fluid challenges to say whether the patient still requires fluid or not. We should monitor the patients, ideally using the dynamic parameters. So take-home messages are that effectiveness of fluid therapy depends on volume, quality of fluids, infusion rate. A fluid therapy with balanced solution causes less disturbances compared to non-balanced solution. Very often this fluid therapy must be connected with vasopressors. We have to choose fluid correctly, correct patients, correct time, correct volume, and we should use good monitoring. And I think that this is the almost last slide. If you imagine how colloid, crystalloid, and glucose works in the body, you see it here. Colloid, mainly intravascular compartment, but colloids should be used very cautiously. Crystalloid fill intravascular and interstitial compartment. This effect of intravascular compartment is short, and glucose fills intravascular, interstitial, and intracellular compartment. It means that also cells, intracellular compartment, cells are being filled with water after infusion of glucose. So remember, in brain edema patients, never give 5% glucose because you will pump the cells in the brain. If there is edema, by giving extra fluid, you will increase this edema even more. This picture, this slides shows, in my opinion, in the best way, helps you to imagine in the best way how what effect you can get after giving the patients different types of fluids. Yes, so just keep in mind this is for your future, for your clinical practice. Okay, so with this I will finish because the next slides are only is only what I've already said. This is, in my opinion, very important slide. Okay. Any questions?
No, not really.
If you have any questions, I know this subject. I know that this subject is very big one. There's a lot of information. At the beginning, I've said that fluid therapy is a difficult task. I hope that you've understood that this is difficult. And please remember that fluids are drug. And by giving them too much, you can do harm. By giving it not enough, you can do harm. By giving incorrect fluid, you can do harm. So giving the patient's fluid, intravenous fluid, is not just taking a bottle from the shelf and connect it into the patient's vein. There must be thinking. If you don't remember what is in the bottle, what is the composition of the fluid, look at what is written on the bottle. On every bottle it's written what is inside. How many sodium, how many potassium, how many chloride, and do not give somebody who has too much sodium solution that contains only sodium, or do not give a patient who has high potassium level, who has hyperkalemia, solution that contains potassium. So we always have to check, have to keep in mind what is the patient's condition. Okay. So if you don't have questions, I will stop recording now and I will finish. If you will have questions and you will feel good and it will be safe for you to come to the hospital, you can always find me in the department and ask some question concerning the subject. I don't know whether we will have the practical exercises here in the clinics. If you will be in the ICU, for sure I will show those people how we monitor cardiac output, how we use PICO device. If you will come to our unit later next year or during the summer, summer